pandemic is associated with the distress, anxiety, fear, depression, insomnia in general population, and also among the healthcare professionals. So this 2 days webinar will focus on suicide prevention strategies to reduce risk factors and increase resilience and coping at all the level of the society, from individual, family, and level, social environment. And we all know that prevention strategies are needed to promote awareness of suicide among masses and commitment to social change. With these words, I would like to welcome all the speakers, resource persons, participants, my colleague and students for today's webinar. And I request Dr. Sonia Devi, Professor and Head, Department of Psychiatric Social Work, LGBRIMH Tezpur, to give a welcome address. Ma'am has done MSW from School of Social Work, Roshni Nilaya, MPhil, NIMHANS, Bangalore, and PhD from Department of Social Work, University of Mizoram. She has many publications in national and international journal, and she's also been part of many international and national research projects. Ma'am, please, ma'am, for a welcome address.
Good afternoon, good evening. It's also good evening for some people across, because we have one of our resource persons speaking from Australia. So, dear professionals, students, faculty, and all my kindly, especially in this prolonged period of COVID-19 that's hit humanity, spared none across the globe. And it does play, this pandemic itself does play, a lot of strange, it just plays on the mind in different and strange ways to each one of us. Each one has a different way of looking at it. I welcome each one of you for this 2-day observation, the webinar that is there. It's most of the time in the evening, the slots are in the evening for India. And we observe this day in order to, it's the World Anti-Suicide Day. And this day is observed all over the world. And for this webinar, we have with us our director, the Dr. S.K. Deori. He hardly needs an introduction in the field of mental health. He has been in this institute for the last 2 decades as the director and has given vision to this asylum that it was long ago. And he is trained in his field from NIMHANS and in the Central Institute of Psychiatry. We welcome him for gracing this occasion and sparing his time to be with us to give us a brief inaugural address. And we also have others in the fraternity as speakers for this 2 days webinar. We have Dr. Ken Kalita, who will be elaborating on the theme of the webinar, and he is the associate professor of psychiatry, and he's been with us in this institute for the last 10 plus, or rather more than a decade as of now. And he will be talking on the theme of this webinar. And he would be elaborating on this issue in detail to some extent. And of course, the invited speakers will be giving us all the details. And we also have people across the country. One is Dr. I think on the second day we have other people, but on the first day we have Dr. Siddiqui, Sadiqa Sahu, who's a professor of the discipline of psychiatry in School of Medicine and University in Queensland. And he is trained in Central Institute of Psychiatry. And we thank him a lot for being with us. He is obliged to speak on the areas. He has done a lot of work in various areas. I think he has a wide area of interest, and of course this area also is an area that he deliberates on. And we welcome him for this webinar. We have also with us Dr. Alim Siddiqui. He's from Lucknow. He's a private practitioner, and he has done his qualification in psychiatry from the Central Institute of Psychiatry at Ranchi. Thank you for being with us and obliging us by your presence. We need to know everybody's opinion, people across the country, across in private practice, across the government system, and also for youngsters. So we have included a fraternity of persons to be on this webinar. Later in the second day, when we are having the panel discussion, we see that even youngsters will be on the board. Another person who is important to us is a media personnel, and she is Sabar Rahman from the Indian Express. She's associate editor from this Indian Express, and she's trained in journalism. And we definitely would like to hear her and tell us, the media is all agog with suicide, with all that's happening around. So definitely it has a great role in spreading mental health and also bringing down the stigma attached to suicide. It has a huge role to play, and you play a very important role in this seminar. And we also have on the second day, that's for the first day, these are the speakers. And on the second day, we have other people coming in. We have basically Dr. Anish Cherian. He is the associate professor at the Department of Psychiatric Social Work. He has been mainly working in the public health area, public mental health area, and his area of interest definitely is suicide, and he has some collaborative research going across the country in this area, in the area of suicide. And he will be with us, and he is an authority in the area of suicide prevention. He also has all his, who are working on the area of suicide, who are working on their PhD facility. They're also on the panel discussion the following week. We also have Dr. Priya from St. John's. She's from the Department of Psychiatry. She's the associate professor, and she will be with us also on board for the panel discussion. Apart from this, we have other people who are part of this webinar, who are all gathered here for this webinar, and each one can contribute in some way or the other. We have the chat boxes open, where you can put in your message wherever possible, whichever possible way we will try to address. And I hope this webinar will be of interest and it will take forward, and we hope that the youth, we have a large number of people from, the students, the youth, and, people from colleges attending this. And for this, though we would have liked to open it to a larger number of students to take advantage of this. And our target definitely are the youth. And we definitely know that youth are the torch-bearers for this, for the future. And you need to, as youth, I think the youth are the persons who need to carry forward the message, the anti-suicide message, and messages for prevention of suicide is very important that the youth carry forward this. And you need to take, as youth, they need to take the leadership in order to show that there is light beyond the tunnel for life. And with this few words, I would like to welcome each one of you for this webinar, and hope we will all take advantage of this to know better, and so that we can help somebody or other through this knowledge that we have gained in this learning activity that we have put together through this webinar. Thank you.
Thank you, ma'am. Now I request Director Sir, S.K. Devi Sir, Director LGBRIMH, to deliver his speech, sir, please.
Namaskar to you all. Good afternoon. And I'm very pleased to be a part of this platform today. And these are very challenging times. And I understand it's going to be a really helpful exercise on the part of everybody, all of you. I can see many experienced and dedicated workers in the field who will be deliberating on this 2 days workshop. I have been, though I was trained as a psychiatrist for a long time, I have associated myself with mental health administration. So what has struck me in this is, these are the times when I get a feeling, I request you all to look into this. One is, suicide, I think the rate is going to be very high by the end of COVID. That's a projection made everywhere. It's around 1 million in a year. Now we may be hitting around 1.4 million by the end of 2020. So what happens is, another striking features in this is that most of these people who commit suicide belong to the age group of 15 to say 30. They are the majority. So what happens is the most productive people of our country, of the society, gets stricken by this. So what happens is, once you have that ideation somewhere, this is how the mental health, when we have to have a planning for this, this is how we'll have to think. I'll request you all to give us ideas about this. One is that ideation goes around in somebody that suicide is a possibility. Then there is ultimately it ends up in execution of the act. So the time between these two may be long, time between these two may be very short. So what we need is, we need somebody to create interface between these two phases of a person, where we can either focus in the part one, that is reducing the part which is compelling somebody, forcing somebody to consider, contemplate, or think about suicide. That will include a lot of theoretical exercise, definitely. Then later on, to get this thinking into action, they will have to have some type of a facility. So in between these two, our understanding is a lot can be done to prevent the act from happening. So much to all this, I definitely look forward to gain from this workshop in these areas, and I have seen a lot of experts coming and talking, and we'll be talking on this. And with this few words, I will not take up much time here, and we can see a lot of interesting speakers are there, and I hope all of you very good and useful time through this webinar. Thank you very much for giving me the time, and I look forward to joining you all for the next 2 days. Thank you.
Thank you very much, sir. Now I request Dr. Kamal Kalita, sir, Associate Professor, Department of Psychiatry, to talk about the theme, working together to prevent suicide. Sir?
Yeah. Hello, am I audible?
Yeah, sir, you're audible, sir.
Respected Director, sir, Sonia Madam, the persons from Department of Social Work of LGBRIMH, and other staffs and students of this institute, and the participants. Today is the World Suicide Prevention Day, and as welcome address has been said, that it's a very vast topic, and it has got multiple implications in this topic, and where we can actually work together in collaboration, so that we can progress in what we call knowing the phenomenology, what can be done, and what are the other issues. So if we see this time, the theme is working together to prevent suicide, which has been here since 2018. We all know that from 2003, that in the International Association for Suicide Prevention has started this day as the what we call World Suicide Prevention Day. This was in relation to the call by WHO. That's and they have initiated the Global Suicide Prevention Initiative, mainly with the objective of increasing the awareness at various levels, and also to help different countries for developing capability for having different national policies and plan. But the issue here till now is that as of a study done by the WHO in 2004, one-fourth of the countries, one-fourth countries of WHO signatories, suicide is still considered to be an offense and it's punishable. And in most of the countries, they do not have a national suicidal prevention plan. And it's not only in low and middle income countries, LMICs, it's also in the high income countries. So there is enormous need that something needs to be done in this area. And the pandemic has brought us to a level that we may face some kind of humanitarian emergencies in the coming days. So suicide, it's let it down. It means that it kills self. It's kill oneself, and it incorporates many things. It's a process. It's an act. It's an outcome. So there are many things. And if we see a synonym of suicide and antonym of suicide in English language, there are hardly any other word that can give this meaning. But if we see in Sanskrit, probably I got more than 12 words that depicts different methods, different processes. So in a nutshell, that the suicidal ideation behavior that may include the act, the process, the outcome, and the issue becomes more complex if we include euthanasia, martyrdom, than the self-sacrifice issues, suicide bombing. This becomes much more complicated, and probably that's why. One question that emerged is that suicide is there from time immemorial. Mahabharata also describes Arjuna, contemplating for the suicide at the time of Kurukshetra war. But some issues whether the thoughts related to suicide, the whole phenomenological processes has remained same throughout the century, or there has been some mutation. There is not that much of work done in this area. Again, issues regarding whether suicide is very unique to the human race. There are lots of movies depicting that sometimes pets commit suicide for reasons obvious. In Assam, a place called Zatinga, where suicide related to birds has been described from a very old time. And at microorganism level, Toxoplasma gondii, so they also say to commit suicide by sensing the behavior of rodents. So or suicide long time back. So it's seen across some species. So there are different in organisms it is seen. If we see from the ancient view, religion is a very it has developed over time, and it's a pretty old thing. So how does religion play its role? If we see the Abrahamic religions, they are a bit neutral. Islam prohibits suicide in Quran, and in Hinduism, one school says suicide to be very heinous crime. There is no mukti for apamittu, but again it says about the Issamittu kind of thing also. There are different stories in our Hindu mythology in which there are Issamittu kind of thing. Sati was one issue that was also related to suicide in social circumstances, which has been prohibited in the country to a different act in the country. And in our practice also, we see that at times religiosity plays a significant role in the act of suicide, whether they will commit suicide or it becomes as a resilience or a helping thing in this thing. So we need to understand those issues. Here, I would like to mention one book in which that name is Phenomenology of Suicide, edited by Ian Mars. He had committed that actually suicide has been depicted differently in different cultures over different times. And this is out of convenience actually. And he has cited Van Hoof, said that in ancient Roman period, suicide was actually was a honorable act, but in villages it was a heinous crime or it's a sin. And of late, a medical angle has been given, so that's, he tells that it's a model of convenience in describing suicide. We know Sneedman, who has given a psychological autopsy concept, and he actually initially told the concept of Psychiatric, in which he told that every suicide is related to some kind of ache in the psyche, some kind of mental trauma. And based on those things, as well, Joyner, nearly a decade back, has given a new interpersonal theory of suicide, in which he tells about some kind of unmet mental needs. So that's one angle of looking at suicide. In another angle, from the anthropological point of view, they say that these models are actually very reductionist view, and they tell of the concepts of free will, the concepts of subjectivities, culture, and the aspects are much more broader than that. Hill was another suicidologist. He actually told that suicide actually cannot be understood, and it's totally inscrutable by any outside observer. So he gave a totally defined kind of view in case of suicide. Pompili was a phenomenologist who has done lots of clinical work in suicide, and he compared suicide to fracture. He says that suicide is fracture within the self, with other significant persons, with the surroundings, and to the experience of feeling well-being and to appreciate that feeling. So it's suicide. It can be fracture at multiple levels. So that says about the holistic, multidimensional aspects of suicide, which is related to these things. And in a book called Farewell to the World, The History of Suicide, one scholar, Barbley, he said that although there are lots of researches, but quality research is not very much. And the actual answer that we look for it's barely told. So if we see for the facts, it's said that for last 1 decade, nearly 8 lakh people has been dying annually out of suicide, and of which 1 lakh people is from India, and it's in the 15th global leading cause of death. And in case of young people, as told by the directors, that it's the number 1 cause in 15 to 24 years of age. So that's the period in which somebody builds someone's life. So that's very, it has got a large economic impact. And it says that one suicide impacts at least 135 people, his families, friends, nearby people. And at the recent globality is said to be around 11.4. And the recent, the National Crime Review Bureau, report that has been just published last month says that in India it is around 10.4 per lakh population. And of the global population, nearly 75% is currently happening in low middle income countries, and Southeast Asia is at the top kind of thing. Of our religions, neighbors, Sri Lanka has got a very high rate. And in India, 5 states account for 50% of total suicide. That's Maharashtra, Tamil Nadu, Karnataka, Madhya Pradesh, and West Bengal. In Assam, the rate is lesser than the national average. It's around 6.9 per lakh population. Another topic which has been often referred is the pharma suicide. And it's around 7.4% of the total suicides. And nearly 10,000 people died last year of who were farmers for various reasons. And in India, over last 1 decade, in the methods, there hasn't been that much of science. Nearly 78% people still die by hanging or by consuming poison. Nearly 50% die by hanging, and the rest is by poisoning. The use of firearms are quite lesser in our region. And in metros, there are some thing regarding mass suicides. Of the causes, family problems and the relationship issues are at top, amounting around 40%. Illness is 17%, which is a bit more than the previous reports. So the causes are multiple. And here, how people can associate. Actually, we all have role as friends, family members, neighbors, concerned citizens. Everybody's role is there in this suicide prevention program. We may help by creating awareness to various modes nowadays. Social media is a rich tool to reach people. Then to know about the different warning signs, and whenever needed, we can help the needy people. The WHO has run 1-minute program in which there is the advocate about active listening and storytelling kind of thing. And the impact can be life-changing and it can be long-lasting. So again, another area in which probably we need to work with the technology people, in which there can be help of technology. We see sometimes that Facebook and other social media at times using it to prevent those things. The role of media will be told. Then the role of teachers, administrators, this will come. How we can help the mental health professionals, we can help in generating proper research in all the domains. We can guide or help the policymakers and other people, helplines, properly coordination. So that will help. Sweden has seen a very good result with better helpline things. So that's one thing. Another issue, the issues regarding universal precautions of life skills, school education, the emergency situations. So in meeting the challenges, mental health professionals has got a very specific roles. And in this whole journey in India, in of late, we have seen some kind of changes. National mental health policies 2015 specifically mentions about reduction of suicide as one of the objectives. It tells about intersectoral collaboration. It also tells about emergency situations. So that's in the policy part. In Section 309 has been now decriminalized after this Mental Health Care Act that has been passed. So something is moving in the right direction. There has been a suicide prevention, what we call part also in the National Mental Health Program and the DMSP component. But issue is that all those things need to be put in proper way, and we need to work for its betterment through data generation. So in what we call NATSID, we can work better, we can prevent suicide through better collaboration, cooperation, and coordination with a better commitment. So with these few words, I would like to conclude my talk regarding the theme of this year's what we call Suicide Prevention Day. Thank you.
Thank you very much, sir. Now I request Dr. Sadicha Shahu, who's a professor in the discipline of Psychiatric, School of Medicine, University of Queensland, Australia. I request you to please start with your talk. There is an announcement for any questions for the speakers. The question can be shared in the chat box, and we are also live on YouTube and Facebook. There also you people can text your question in the chat box. All the questions will be taken after the presentation of all the three speakers. Then we'll have a discussion based on the question raised by the participant.
Right. Thank you. Good afternoon. Can you hear me?
Yeah, you're audible.
Okay, thanks. Hi, it is evening over here, so I'm just going to say good evening, good afternoon, wherever you are. I'm using this application for the first time. I'm not sure if you've got the presentation up, Dr. Ali. Have you got a presentation up?
Please share the presentation. Arif.
Yeah, I just sent it to the email about 10-15 minutes back. If it's possible to just open that up.
Dr. Sahu, if you want, you can use it from your own laptop or desktop, whatever you are using.
Is it, do I use?
Yes, you can do just, yes.
Right, your entire screen. So, what do you share? Okay, fine. Okay.
Yes, it's visible.
Okay, that's good. So, I'm going to be talking about the COVID-19 pandemic and its effect on mental health from a world perspective. And most of this talk is going to be about numbers, but I'm going to try and see if I can give you a few personal experiences that I've had while combating COVID-19 here in Australia. Now, just to give you a background, I'm a CL psychiatrist. I'm a consultation liaison psychiatrist. So I basically see patients all over the general hospital. I have, I guess, the most amount of exposure to COVID-19, at least in the general hospital that I work. So if I'm able to share some useful information, it will be great. Right. So the challenge of managing COVID-19 currently by public health systems, especially seeing the burden that it's put on the public health and well-being profoundly of people who are involved in giving care, fears and worries about personal safety, a lack of effective vaccine or treatment that we know. We are all hearing about it, we don't know whether it's going to come. Adverse socioeconomic consequences like unemployment resulting from lockdowns and lack of access to necessary commodities that have examined pandemics and natural disasters, that most commonly psychological distress often follows these natural disasters or pandemics or even economic crisis. Depression, anxiety, substance use, increased suicidal behavior and PTSD are the most common diagnosis. And we anticipate that similar patterns are likely to be observed even after this current COVID-19 pandemic. Mental health outcomes of quarantine previously has found that depression, anxiety disorders, mood disorders, post-traumatic stress symptoms, sleep disorders, panic, stigmatization towards people who are in quarantine, low self-esteem among the people who are in quarantine, and lack of self-control are often highly prevalent among these individuals that are isolated physically. And stigma have often resulted in long-lasting post-traumatic stress symptoms, confusion, and anger in the mass population. Anxiety symptoms, fear, and lack of hope regarding uncertainties in treatment and health outcomes. So patients often don't know, what happens if they contract COVID-19. Are they going to become worse? Are they going to get better? Since we really don't have access to proper treatment or even a vaccine. Then when there is prolonged hospitalization and when these people are put in quarantine, they also face significant discrimination and stigma. And there's a lack of social support that accompany the care of these patients. The providers, the healthcare providers who are delivering the care are also susceptible to anxiety, depression, burnout, and insomnia as they grapple with the expectation of not just patients, but also of the healthcare system to provide care for these patients. Fear of contracting the infection, lack of social support, working under stress, guilt about suboptimal care to the patient, or even leaving hospitals understaffed. These are the main worries that healthcare providers like us go through, which are really additional psychosocial stresses. So it's important not just to recognize the impact of COVID or any pandemic infection, not just on patient, but also on healthcare workers. Now, what's the data say? The data, and we don't have a lot of data, most of it has come from China. COVID-19 and mental health in general population. Researchers in China have estimated and there are not many studies, there are about 3 or 4 only, in various studies, the psychological outcomes of this pandemic. Depression has been found to be ranging from 9%, which is at the beginning of the pandemic, to 44% at the peak of the pandemic and during strict lockdown. Similarly, anxiety disorders has been found to be around 8% at the beginning and about 37% at the peak. In fact, it's been noted that the per day number of anxiety screenings completed in May, when we had a peak, was 370% higher than in January, when the coronavirus actually started. The per day number of depression screening was 394% higher in May than in January. So you see the significant jump in the number of people presenting with depression, anxiety in screening as well as in being diagnosed. And these studies have also found that PTSD was present in around 14% of respondents. I would like to highlight that these studies have taken a sample of the population when they are So it's only among the respondents that these numbers apply. Now, there are very few studies from outside China. There's a Turkish study that has found that the depression prevalence is around 23%, and anxiety is around double of that, about 45%. A study from the US observed that suicidal and self-harm behavior is around a third of all new depression and anxiety cases that have been associated with COVID-19. So every third person that's presented with depression and anxiety has also indulged in self-harm or suicidal behavior. An Indian study observed a very high perceived need for mental health services. So up to 80% of people felt that they had to access mental health because of all the worries they had. And the most important issues that they were grappling with were sleep difficulties, paranoia, and COVID-19 worries that are predominating. There are case studies that have been reported from India, Pakistan, and Bangladesh that have reported individuals committing suicide in fear of COVID-19. In fact, I'll share a case that we had come across. So there was this patient that had come back from the UK, and she was here in Brisbane, where I work, and she was asked to quarantine because there was a reported hotspot in London at that time. So on the second day, because of fear that she possibly had coronavirus, she actually jumped from the third floor of a building. She ended up with a lot of injuries, but she survived. And we had to assess her mental state and admit her for a brief period of time till everything was cleared. She didn't have COVID-19, but this is just to say that often individuals who have a fear of having contracted it and they're so uncertain of the outcome can also engage in self-harm behavior. Now, looking at the mental health of patients who've actually contracted COVID, they are COVID positive. Now, these patients have higher levels of depression, anxiety, and post-traumatic stress symptoms compared to non-COVID controls. Huang and Zhao observed that GAD, is a generalized anxiety disorder, and depression was present in about 35% and 20% of all COVID-19 positive patients. COVID-19 also seemed to affect patients who were already had a psychiatric diagnosis previously itself, as anger issues, impulsivity, and suicidal ideation were much higher in psychiatric patients compared to healthy controls. Please remember that these are people who already had a diagnosis of some psychiatric condition. A recent meta-analytical review of 12 studies has assessed mental health among 976 patients with COVID-19, and this was just to see the neuropsychiatric consequences. And in this, they found that delirium, confusion, and agitation was most commonly observed. And more concerning was that about a third of COVID-19 patients experienced dysexecutive syndrome following discharge from the hospital. So they were left with long-term neuropsychiatric consequences even after they had recovered from COVID-19. How does COVID-19 affect HCPs? What does the research say? So HCPs are healthcare providers. Several studies have noted higher prevalence of depression and anxiety in health providers dealing with COVID patients. Frontline health workers with close contact with COVID patients were 1.5 times more likely to experience fear and nearly twice more likely to experience anxiety and depression compared to non-clinical staff. More than half of all nurses who work with COVID patients reported negative emotions, worrying about the family, fear of getting infected, and increasing stress about the heavy workload. There's also poor sleep quality and burnout that is higher among frontline workers. Several studies, again conducted in China, have observed high rates of depression, about 40%, anxiety, about 25%, and PTSD, about 10% among doctors and nurses. And only one study that examined 906 healthcare workers in Singapore and India observed about 9 to 10% prevalence of depression. This is compared to the general population. So again, I'll give you an experience that we had about a patient, a fellow doctor who got infected with COVID-19 while working with mental health patients. And there was so much of anxiety, and this is a psychiatrist who got infected. She was so much anxious that her family was infected, and she was worrying all the time, even though she was quite healthy and made relatively a good recovery there was significant amount of depression and anxiety that she struggled through for the 3 to 4 weeks that she was quarantined and tested until she tested negative. So it's quite common that nurses and doctors who are working in the front line dealing with COVID patients struggle significantly with depression and anxiety, as well as significant worries about what's going to happen to their family members. They're going to go back home. Are they going to get infected, etc. Now, what are the factors that are associated with mental health problems during COVID-19? So age. Younger people have been noted to have higher rates of GAD and depression. Gender. Female patients had been observed to have higher rates of depression, anxiety, and perceived helplessness. Among that, education. Low education associated with poor mental health outcomes, with higher education offering some protective role. Occupation and income. So people with property loss and adverse economic conditions were more vulnerable to mental health problems. In India, the poor are more likely to be adversely affected by economic lockdowns. And we see that, it's so obviously clear when we see that in the media, that the poor are suffering significantly with the lockdowns. If patients have comorbid physical health problems like diabetes, cerebrovascular diseases, heart diseases, and other chronic conditions, they experience significantly high rates of depression, anxiety, stress, and PTSD. Now, this is not uncommon because the media, as well as recent understanding, is that if you have a chronic health condition, you're more likely to have an adverse outcome from experiencing COVID-19, resulting in higher mortality rates. Exposure to media. Now, this was interesting. Spending more than 2 hours per day on COVID-19 related news and social media was associated with increasing anxiety and depression among community-based adults. Other factors that were noted was stigma to COVID-19 is associated with an adverse mental health outcome and increased suicidal behavior, whereas regular exercise was highly protective against experiencing psychological distress. So I've spoken about mental health generally because suicides are mostly among case studies, but this is a kind of a hypothesis as to why people could commit suicide, especially when they're vulnerable in the COVID-19 era. So if they are COVID-19 and there's so much of uncertainty about the outcome and people are in social isolation and struggling with economic problems, and within them, there are these vulnerable people who have pre-existing psychiatric disorders, have low amounts of resilience, who are residing in high COVID-19 prevalence areas, or who have had a family member or friend who has died of COVID. Now, these people are uniquely prone to be developing either anxiety disorders, depressive disorders, alcohol and other substance use disorders, or other psychiatric conditions, or if they have a pre-existing condition that gets even more exacerbated. And all of these conditions can lead to suicidal behavior as well as completed suicide. I'm going to end my talk here because there are lots of things that can be done to prevent this and as well as address this. And I guess the other speakers are going to be addressing that. So I will stop here. Thank you.
Thank you, Dr. Khadija Shahu, for highlighting the global perspective of COVID-19 and the mental health issues and the society related to it. We are very thankful to you as you have given us the time for today's webinar. Thank you very much. Now I request Dr. Alim Siddiqui, the consultant psychiatrist from Lucknow. I welcome you and I request you to give a talk on suicide, a biopsychosocial perspective. Please.
Yeah, thank you, sir. Thank you, Dr. Deori, Dr. Kalita, Dr. Arif, and all the participants, my co-panelists for inviting me. Let me just start to share my slides. So, are the slides visible and I am audible?
Yeah. Your slides are visible.
Okay. So my purpose of my talk would be to try and find a way out if we can prevent suicide, what we can do actually. As I talked with in the background, most of the people here would be from the psychiatric social work background. So I have tried to make my talk relevant to the audience. So suicide, as we all know, is an act of purposefully ending one's own life. So we can say it is a permanent solution to a temporary problem. The problem was temporary, but the solution that we chose was permanent. Now, there are various variations of suicidal behavior. One is suicide, other are attempts. And there is much sub-classification in those also. NSSI is also one of our big factor now. So, we'll restrict ourselves to suicide and suicide prevention. So, what are basic elements of a suicidal scenario? A sense of unbearable psychological pain, which is directly to constriction of thinking. Only the focus narrows down to the suicide as the only output. So there is a sense of isolation, self of hopelessness. It is an extremely distressing thing if you talk to the suicide survival. So the only equation, the attempt to get away is the suicide action or ending one's own life. So every 40 seconds, someone is dying by suicide, and every 41st second, someone else is left to make sense of it. As Dr. Kalita said, about 135 people are affected by one suicide. So this is the prevalence of suicide as per WHO, 75% in lower and middle income groups. This is the latest NCRB data. So in 2019, this is the latest data that is available. The suicide rate is 10.4 per lakh. It comes out to be 1,39,000 persons committing suicide. Mind you, this is only the reported data. And as we know, the reporting systems that we have in place, it is likely or almost we can be sure that it is much more than that. Now, this is the state-wise distribution of the suicide data. So, this yellow graphics, these have the maximum suicide rate: Chhattisgarh, Telangana, and Kerala. So since the institute in Assam, it says 6.9. Assam is having 6.9 per lakh suicide rate. NCRB says that family problems, illnesses, and drug and alcohol, these take more than 50% of the causation of suicide. And as per the it's trying to jump out from it. Now, why are they jumping out? They're jumping out because the building is on fire. There is no escape route available. Now, if that fire Patient will say, I'm thinking of ending it all. No one can help me. What is the use of living? I wish I were dead. अगर मैं नहीं होता, no one would miss me. I won't be needing things. I'm a loser. I can't do anything right. Life is not worth living. I just want to sleep forever. So all these statements, when you do mental status examination, if you find these statements, consider them these as red flags. So you have to work up for suicide risk. Behavioral science, writing about death, writing a death note, making your will, putting affairs in order, not paying address to physical needs, eating too much, eating too less. So change in behavior, sudden change in behavior, which is not warranted. In psychiatric patients, what are the risk factors? Command hallucination. Sometimes we have the patient saying that you jump from the roof, paranoid or personality delusions, severe depression. Depression is so severe that it is getting psychotic. Depression with suicidal ideation, alcohol and drug abuse history, extreme aggressiveness or violence is there, anxiety and panic is there, agitation. So all these worked up states. Depression is there with agitation. So this is more of a more potent mix for warning signs for suicide. So what you should do when faced with a person with suicide, you can do is talk. First and foremost step is to mentally allocate some resources. What is this resource? Your talk, your time, your effort. Establish a rapport. So if you're able to form a rapport, I think most of the suicides we can take care of. You can ask questions starting from open-ended to close-ended or whatever is the appropriate thing to do. Remarks like, you look upset, tell me about it. This is a very general open-ended question. आप बहुत परेशान दिख रहे हैं, कुछ अपने बारे में बताइए. Listening with empathy. Now this is an important thing. Empathy is easily said and difficult to follow. So you have to develop empathy, how to feel yourself in the patient's shoes or in the person's place. So a sequence of useful questions could be, do you feel unhappy and helpless? Your day-to-day life. लगता है कि जिंदगी में कुछ कर नहीं पा रहे हैं. Life has become a burden. Life is not worth living. And then you can also ask, do you feel like ending your life or committing suicide? So you can also ask, if the patient says yes, any plans, any means are there, what you have planned, how do you want to do it? Do you have anything in possession, any pills, guns, other means of suicide? When are you planning to do it? So these questions are important. Now, when we had a lot of discussions, most of the patients will feel thankful when you talk about these suicidal ideas. There is a myth that people don't want to talk about. In fact, when a person is saved, you talk to him later on, he will say that I am very thankful, doctor, that you talked about it. So you just start communication. Whatever you can do, try to be in regular communication with the patient. Now, this is the 5-question assessment which you can use for recording in your case record file. Have you ever had a suicide attempt? Are you feeling hopeless about present and future? Have you recently been thinking about suicide? And when was the last time you thought about suicide? And what is likely to make you think about ending your life? So this is a 5-question assessment. This is also a procedure that can be done. So you have to talk when the rapport has been established, when the patient is comfortable about expressing, and patient is in the process of expressing negative feelings. Now, why it is important? Talking, rapport formation, and various cognitive techniques that we all know of. Now, the second thing is impulsivity. Suicide impulse can be there, but by definition, impulse is a time-limited brief phenomenon. Now, जो चीज थोड़ी देर के लिए हो रही है, if we are able to tide over that time, that suicide impulse is overcome and the suicide action could be averted. Now, the third thing is rigidity. Now, if a person is very constricted towards thinking only on suicide, then it needs a lot of cognitive strategies, but still rigidity can be tackled. So, these three psychological domains are going about, and if you are targeting these, then you have a better outcome. You can enlist support, you can make a no suicide contract. So this could be one of the safety plan indicative. Uh, what what are the things you can note down this? What are the warning signs that I should be aware of? Whom should I contact if I'm feeling restless? Friend or professional agency that I need to contact upon. So if these things are ready, if these things are with the patient, then patient can take help of all these points that are kept on this slide. Uh, 2 points of question. If everything was wrong and now everything is suddenly getting okay, so it could be a misleading or false improvement. Improvement could be false also because there was agitation, confusion inside the mind, but now I'm very much, I have decided to commit suicide. So there is less of agitation, the patient will appear calm. So if there is improvement suddenly, kindly be on very high alert. Or patient who is denying. Uh, Patient having serious intentions may deny having any such ideas. In fact, I lost a patient. He came to follow up. It was few years back with his wife. Everything was going fine. He was very calm. He doesn't know, the family doesn't understand. Even I don't understand why the suicide happened. So there are things like that that can be that we should be cautious about. Now, if you want to make a sort of risk assessment, this is one of the indicative things what to do. Suppose there is no societal risk. To peak, then there should be no qualms about hospitalization. For certain intervention, Psychiatric Society, we are doing a lot of webinars. To use of event, I think the next speaker will address that. A lot of wrongdoings are going on. So, formulation of pesticides, over-the-counter pills, guns are not freely available here, so this is not such a problem. So, all these policies to be part of the suicide prevention plan. How I'll explain just in a few slides. Some medications such as antidepressants, lithium, clozapine, ketamine, have been found to have anti-suicidal properties. These are part of a separate presentation. ECT is one of the most maligned, but one of the most effective ways of preventing suicide in a depression patient. Psychotherapy is one of the very important tools how to engage, how to talk to the patient so that the suicide is prevented. So this I was talking about. Gatekeepers. If we have gatekeepers which do not allow the person suicide, he should believe that suicide can be prevented. He should have an open mind, learn basic intervention skill, has the confidence to respond, he has the ability to form a rapport and can assist in these sort of health professionals. So carry this message everywhere. Wherever there is a big organization, all the mental health professionals should train one or two people. Now it all depends on the how the organization is taking up. So form a rapport with the big organization, train people there. They will be your referral source. They can bring you the patients who are in need of help. So these are some of the helplines that I could collect out. I have not personally checked, so I think I'll request you to kindly check before referring a patient. Prerna Group, Sneha Group in Chennai of Dr. Vijay Lakshmi ma'am is doing very good work. Empower Minds in Bombay, I personally know the people. Nimhan's helpline is there. This Kiran Ministry of Social Justice and Empowerment helpline. This helpline has been launched just a few days back. So there are many helplines IT has. Right. So it goes right through your privacy right. So, and it will take infinite times the effort of a polio campaign to save everyone. So my basic message to you is whatever can be done should be done. With very limited resources, we can do quite a lot of good. So thank you, and this is my alma mater, Central Institute of Psychiatry. Thank you everyone for your patient listening.
Thank you, Dr. Alim Tadiki, for giving an about suicide, the risk assessment, about the intervention, about the awareness program, and all. Definitely, your talk is definitely going to help the. To speak up about her topic, how does media portray society?
Hello, everyone. Am I audible?
Yeah, you are audible.
Okay. Thank you for this opportunity. And I'm from the media, yes, the much maligned media. And as Mr. Siddiqui said, a lot of wrong things are happening around, and he expects. The next. Speaker to address count for about 21,359 cases, which is 51.4 percentage wise. The suicide rate among the unemployed people in 2019 accounted for 10.1%. And the highest number of suicide was among the student community in 25 years. In 2019, the number was around 10,335 cases. It means every hour, one student died by suicide, which is about 28 such suicides reported every day. So in all, the total number of suicide in the country increased to 1,39,123 in 2019 from 1,34,516 in 2018. This is the 60% of this number were young adults. And if we break down this data further, it means roughly 381 suicides in a day. So that is a very huge number. And herein lies the challenge for the media and also its responsibility to pick what it should report on and what it should not. And most importantly, how. So most newspapers had front page stories, and they also had stories in their inside pages about stories with headlines on farmers, daily wages, unemployed people, students, and housewives. Also had So this phenomenon has a name. It is called suicide contagion or the Werther effect. So the impact of sensational reporting of suicide and the subsequent increase in suicide rates was first studied by sociologist David Phillips. So Phillips found suicide rates to be higher in the months when the US press had front page articles on suicide compared to months when there were no such articles. He was the one who coined the term Werther effect. The term
बहुत डिस्टर्ब हो गया यार, चल ही नहीं रहा, पता नहीं क्या है।
Harassment and discrimination because Payal belonged to a tribe, a scheduled tribe. The three, according to the charge sheet, we have Payal, there are Payal's friends on record saying that Payal would be, these three seniors who are accused in the case would ask Payal about her NEET score. They would slight her, they would shout at her, they would tell her that people like you, reach scheduled tribe, are good enough only to be clerks. So there are, these are such stories of trauma and discrimination that need to be highlighted, that need to be spoken about often. Now, human rights activist Bezwada Wilson in The Wire has said that suicides in an unequal society like ours cannot be generalized. He says suicides by members of marginalized communities may have a unique reason and various social factors and discrimination behind it. And these need to be highlighted. And they have to be separated from suicides that stem from individual woes. In this respect, there are editorial guidelines and they vary from organizations to organizations. But you only have to use common sense here that tells you that suicides of deprived people need to be highlighted. So journalists who cover farmer suicides say these suicides need to be examined as part of a larger narrative because they are part of a narrative that involves agrarian stress. They involve economic deprivation. They involve inaccessibility of government schemes. So you have to dig deeper there. Then we also saw NCRB data that says that housewives account for more again, these stories need to be chased, need to be done, need to be investigated. So but at the same time, all discussions and debates should happen constructively. They have to, the motive has to know the causes, what made these people resort to such drastic measures. Now, last but not the least, we need to talk about the pandemic and the fear and the trauma and the mental stress that this unprecedented situation is causing. WHO has called upon countries across the world to pay greater attention to mental health and suicide prevention. The same goes for the media. It has to pay greater attention to stories of mental health and suicide prevention. And while it reports these stories, follow with changing information is triggering and aggravating existing and pre-existing mental health conditions. That needs urgent attention. Then there's this whole stigma related to COVID-19 infection. This is leading to feelings of depression, isolation, and even there have been attacks on doctors. So I would say media would refrain from such headlines like COVID terrorist or COVID ka kahar. So that these sort of headlines only make the situation worse. They only make people more fearful, of not only the pandemic, of also the people around them. there is joblessness around, there's economic distress around. I think media houses should look at stories of human interest, health, joblessness, and economy. Another factor impacting mental health right now amidst COVID-19 is domestic violence, which is reported to have increased during lockdowns imposed by almost all countries in the world. National Commission for Women has spoken about it. Media has done a lot of stories on this. But media has to be alert and watchful about this.
गुंजा वहां से वो देना तो मॉडम वाइट वाला
Question from the chat box. So shall we start? Yeah, so few questions are there. I think Dr. Aleem and Dr. Sadiksha will answer these questions. One question is like,
And not every depressive patient is suicidal, and not every suicidal patient is depressed. However, we also know that depression has one of the highest suicide rates. And this is, I guess, closely followed or sometimes even increased if you have psychotic symptoms or if you are experiencing schizophrenia. So depression and schizophrenia generally have the highest rate of suicide among psychiatric population. So if the question is, can depression lead to suicide? It's not a blanket thing. There's no blanket rule that if you're depressed, you get suicidal. Suicide is a cry for help, as Dr. Siddiqui has mentioned before. It's often that people engage in behavior because they have nothing else to turn to or no one else to talk to. And that needs to be treated as such. But we also need to understand that making these assumptions that just because somebody's depressed, they're going to be suicidal is also wrong.
We'll take another question. How social deprivation influence to commit suicide, especially among the middle class people?
So I think social deprivation, one of the risks that I talked about in the slides also, being in a good integrated social system is a preventive factor. Being isolated is a risk factor. So I think the sort of family structure that we are having, we are too much into each other. जो usual हमारा जो Indian setup है, we like to talk to each other. We have good interactions with the family. There is less of social isolation. But now, since the nuclear family, their urbanization is there, so you any elderly couple, elderly person who is living alone, so those will be very predisposed to having depression or suicide. So, and I think there is one Ministry of Loneliness form in UK now. So it is such a big issue there that because of loneliness is a very important factor, I think, if you need to address mental health issues.
Thank you, Dr. Ali. Similar to the previous question, one of the participants has raised a question like, if someone try to commit suicide, if it's because due to that person is unable to cope with a problem, with the failures in life. Is it because due to the upbringing of parents? Please throw lights on these issues. So basically, the person wants to know whether the faulty parenting or failure to cope with the day-to-day stress lead to suicide.
Now, if you look at suicide, it is a behavior. How a behavior is formed? It is formed by a few inputs. The first input is what is the genetic makeup that you inherit from your parents, from genes. Now, these genes encode the behavior that many of the things that will be presented later on. So, if your family history of suicidal actions is there, then you are more likely to have suicide. Now, how your personality is formed? There is a thing called nature versus nurture. Some things are encoded, some things are learned. So, you cannot change your parents, but certain changes in parenting styles can be there. So, if there is faulty parenting, if there is harsh childhood, if there is loss of a parent in childhood, the later on suicidal thought or depression is more likely to occur. So it is an amalgamation of your genetic makeup, your personality having resilience or not having resilience, how is your stress coping, then what is your current surrounding. If whatever you want, by luck, by chance, you have all those things, so there is less likelihood of shifting towards suicidal behavior. Now, if you're in a crisis, you lost your job, you lost your crops, you lost your loved one, या आपकी गर्लफ्रेंड ने आपको डिच कर दिया, those things are triggered. So the concept is the tipping point. हमारे ऊपर तनाव बढ़ रहा है, हमारी तनाव झेलने की कैपेसिटी से जब वो exceed कर जाएगा, then we'll start having bad reactions. So one of those bad reactions could be suicidal action. So हम अपने आसपास का तनाव अगर घटा सकते हैं, if we can reduce the stress around it by various means, then it is well and good. Or if we can improve our resilience by practice, by cognitive restructuring. अगर हम किसी क्लिनिकल साइकोलॉजिस्ट से कांटेक्ट में रहें, CBT पे रहें और अपनी तनाव को बढ़ाएं, it will be beneficial. या हमें अगर दवा की जरूरत है, if you take medications, antidepressant, these can help your resilience. So all these things combined will lead to decrease of depression, decrease of suicidal behavior.
Yeah.
So I'll just add, I'll just add that, as Dr. Siddiqui mentioned, it's a combination of factors. So there are static and dynamic factors. The static factors, as what Dr. Siddiqui has mentioned, are all your genetic makeup, positive parenting leading to better resilience, presence of personality, coping styles, etc. Dynamic factors are the ones that are leading to a sudden precipitation of suicidal behavior, be it a change in your psychosocial stressor, a change in your mood, a change in the psychiatric distress that you're experiencing, etc., etc. So it's an amalgamation. It is never one single factor that dictates whether a person is suicidal or not.
Yeah, thank you. This question is for Ms. Sabha. There's one question. There is always a gap between the reported suicide and the actual suicide. So there's always a misreporting of suicide where there's an accident versus suicide. So would you like to highlight on that?
Sorry, can I hear the question again?
There is always a gap between reported suicide and actual suicide, right? And always there is a misreporting of suicide, whether it's the accident versus suicide. Whether it's the accident, then the suicide has been reported as it's an accident, or actually it's a real suicide.
So you know what happens is, whenever the first response is not to say suicide.
Yeah.
Because we wait for the police or somebody else to say that. So supposedly a body is found. Instead of saying that, I'm talking about the best practices of journalism. Okay, this is how it should be done. So if a body, if say a person dies by suicide, so you don't really say that. You begin with saying that, okay, the person, a body has been found, or a family say has died in a suicide attack. So you just say a family of 5 has been found dead in their house. So that is how it happens. So that the best practice is, and then you also don't give out how they committed, how they died. Since very recently, I'll say a week or 10 days ago, there was a family of 5, a couple in their 40s, their 3 children, 2 twin daughters and 1 minor girl. They all 5 of them were found dead in their house. The police insists it was an obvious suicide pact, because the family, as told by their relatives, that the family was going through a bad time, there was death, and there was the best practice is not to put that in headline. So you just let police say that. So it was apparently the family had consumed poison. So we refrained from even saying that. So let the postmortem report say that. So that is perhaps where the gap happens. Otherwise, media is also the first responders to any accident and to any suicide. So if it is a suicide, the gap happens because they might be refraining themselves from saying that. And if it's an accident, for instance, many this NCRB data talking about housewives dying by suicide. Many of these suicides might be passed off as accidents. Gas, that LPG burst and all that. So so here, along with media, it's the police's job. Both have to do their due diligence here.
Yeah, ma'am, if I can add here, I think there should be a lot of underreporting, because the nature of event is such that many people would not want to come out with it. So there could be very much underreporting.
Has a woman who has killed herself, or the family, we know about dowry deaths. You can pass off a dowry death as a suicide death. So that is the gap. Yeah.
Okay. Dr. Ali, would you like to add something?
No, what is my impression or my understanding would be, there would be a lot of underreporting, because many of those deaths could be passed off as natural death. So sometimes family is also not interested in reporting suicidal death, because then certain things can of once open up. So my impression, this is my personal impression, that the suicide rate is more than what is there in the studies.
I think it's been observed widely, even by WHO, that the statistics in India are probably always an underreporting of suicides. Even the NCRB data is an underreporting of the actual number of suicides. So media can only report what they can. And I think, we also need to introspect as a general population, because, our appetite is whetted by, gruesome things, including stories about suicide, etc. And I don't think it's fair to always blame media to that are trying to cater to this appetite. That's all. I guess Ms. Rahman would have a different opinion or a better opinion, but that's what I.
Can I ask a question, or can I make a comment?
Yeah,
sure. Sabha, ma'am.
Yes, yes, please. Of course.
Ma'am, we at Indian Psychiatric Society are very much distressed by the media reporting going on. So kindly pass it on in the colleagues, in your work, on your peer group, that
Surely.
the doctors are very, we are very disappointed the way certain people, not everyone, but certain things in the media are going on. In fact, since this incident, this media survey is going on, I myself in my OPD have been getting patients who are talking about this event. That जब से वो देखा है मैंने तब से मेरा भी मन कर रहा है, मेरे समझ में नहीं आ रहा है, मैं भी सुसाइड कर लूं. In fact, I can personally vouch that increase of this the complaint has increased in my OPD also. So I think there are various guidelines that have been flouted right, left, and center for the TRPs. I think please pass on this message from us, the Indian Psychiatric Society doctors.
I will, sir. So I would like to say here that there are many in the media fraternity who are equally distressed, and they're not happy with what is happening in the country right now. Because we also understand that my kind of experience, I'm also close to 20 years in journalism. I have never seen media behaving the way it is behaving right now. Okay, so I'm equally distressed. I'm also bothered. It's extremely worrying. I just hope things change for the better. People in the media, and people outside the media, the viewers and the readers have some, better sense prevails in this country. Yes.
Yeah.
Hope so, ma'am.
Thank you. Before taking another question, I request Dr. Kamal Kalita to give few comments. Sir, please.
Yeah, hello.
Any comments, sir, you would like to add on it?
No, it's okay. Merely what we call most of the points have discussed.
Rather than this, sir, another question related to suicide. We saw your comments. Would you like to ask any question or would you like to give your personal comments?
I couldn't get you actually.
So would you like to add on anything you want to share with us in this platform?
No, not that what we call whatever has been discussed till now, it's okay. There is issues with reporting, and this will continue because of the very set of problems or issues. It might not be called a problem. And, what we call regarding media reporting, yes, it serves purpose for some, it doesn't serve purpose for some other group. So there will be a what we call a tussle between those things. So what we call, we have to accommodate each other, and probably suicide sensitization is the most problematic thing which is sometimes seen in media, and when it seems it creates more discussion. In fact, this discussion helps in creating awareness too. So that's one positive aspect of sometimes having negative kind of interpretations of some issue. So that's one good thing. So probably what they call people will discuss about that, and in the coming time it will get a bit positive. But the thing is that with time it can again go to the same level. So continued effort is which is needed very much, because with time society's needs changes, perception changes, and accordingly all these policies or the what we call the ways to deal with those things also needs to be sensed or updated. Thank you.
Thank you, sir. We'll take one or two questions more. There's one question, like in India, there's a compensation. There's a compensation ground with the government services in which the son or daughter get a job if his or father died before the retirement. So some things like employee commit a suicide to get his, her or son, daughter in job. Is there any provision for that?
No, I think I'm not available. I'm not knowledgeable in that respect. Job on compassionate grounds. I think most of the insurance companies, they will refuse your term insurance if there is a mention of suicide. But this government job sector, I think we'll have to look it up. I don't think I'll not comment on that because I'm not well versed in this.
Okay, we will move to another question. What are the ethics needs to follow suicide in pharmacological and non-pharmacological treatment or management? What are the ethics needs to follow?
Ethical what?
Needs.
Ethical
Needs to be followed. Or ethical guideline, you can say.
I think we have been discussing that all throughout. The ethics of discussing is what you can say is first to the person in question, have a non-judgmental attitude. You will be able to talk to that person. उसके लिए जो बुरे भाव या ऐसा बोलना कि यू आर वीक, ये ऐसा सोच रहे हो, ये आपके मन के विचार हैं, खराब सोच है, all these sort of judgmental statements कि हमने एक judgment पास किया कि you are thinking wrong, that has to be stopped. That is the first and foremost thing. इसमें एक चीज और ऐड कर दें कि mental health professionals are just a part of the suicide prevention policy. Suicide prevention ये सबको लेना है, everyone, lay person. So you are a mental health professional, you train the lay person. उनको आप अवेयर करें और उनको जो सुसाइड गेटकीपर का कॉन्सेप्ट था उस तरीके से ट्रेन करें. So to the person, listen, be non-judgmental, give your time and effort. अगर आप किसी को आज अपना समय देंगे तो जब आपको जरूरत होगी, the other person will be able to provide that. So if you make a better society, if you have better cohesion in your family, in your institute, society in general, if you are not running after TRPs only, if you are able to orchestrate these things, तो ये जो ethical चीज बोल रहे हैं, this is very important because हम ethics follow करने लगे तो सब कुछ तो राम राज्य हो जाएगा. So ethics is most important, but it is very easily said than done.
If I understand this question right, I mean, is the listener trying to ask if there's an ethical need to treat pharmacologically and non-pharmacologically suicide? Is that what's being asked? I mean, what is the ethics of treating it?
Yeah.
Because if it is that, then I think, we are quite aware that, as Dr. Siddiqui has mentioned, a lot of suicidal behavior is generally psychosocial stress driven, and that definitely needs non-pharmacological treatment most often, unless and until there are other factors like, an Axis 1 psychiatric disorder, which we will then treat by pharmacological methods. But most of the time, talking to a counselor, psychologist, a mental health professional, if not a mental health professional, at least even a friend, family member, can often lead to a reduction in the prevalence of suicidal thoughts, behaviors, and actions. There definitely is an ethical need to address it.
Okay, thank you. This is the last question we'll take. Why the minor boys and girls are seen nowadays more prone to take the drastic and extreme steps without giving a second thoughts? Just for a small issue or a small matters, they are involved in such kind of behavior.
I think that has to do with the changing structure of society. The minors are no longer minors; they become majors very easily. Age is one thing, but your exposure, the social media is everywhere. So you are exposed to most of the things that adults are at the age you are starting to hold the phone. So I think this this preponement of adult behavior is there. Now another thing, if both parents are working and if there is less of communication, the communication pattern within the family. So that is one of the things. If I am earning a lot of money but because of that money, I'm not able to give time. So what I do, I give a good mobile, I give a good internet connection, or I give money or material gifts. So if there is loss of this parent and child relation, this warmth in the relationship is gone. That would lead to a child taking bad steps. Now, if you are not in communication with your child, then it is I'd say it is more of parent fault rather than child. If there is a problem with the child, actually, what I tell you my experience. When we start treating the children in our clinic, this psychotherapy with children mostly ends up couples therapy of parents. It starts intervention with intervention of child. It many a times end with intervention couples therapy of the parents. Parents are fighting with each other. Parents are fighting in front of child. There is so if we have a good network of family, so what it helps, it gives a cushion. बच्चे को ये बताने का कम्युनिकेशन या ये चैनल होना चाहिए कि इफ आई टेल दिस टू माय पेरेंट्स आई विल नॉट होल्डेड और आई विल नॉट बी जज्ड, मेरी बात सुनी जाएगी और समझी जाएगी. तो आई थिंक जो बच्चों में अगर हमको कहें कि ये चीज ज्यादा दिख रही है, द रीजन माइट बी कि देयर इज लैक ऑफ कोहेजन इन द फैमिली, देयर इज एन ओवरलोड ऑफ इंफॉर्मेशन. इंटरनेट पे देयर आर कम्युनिटीज जहाँ पे जो पीयर प्रेशर की हम लोग बात करते हैं या पीयर सपोर्ट की बात करते हैं, तो वो फिजिकल प्लस ऑनलाइन, ऑल दीज थिंग्स joined together could lead to a bad outcome.
Yeah. Anything?
Yeah, I'll just add to this. I mean, to whatever Dr. Siddiqui has already mentioned. So, you know, the advent of nuclear families, the lack of family time, the possibly poor parenting techniques has led to inadequate coping mechanisms by many of these youngsters. We have to understand that coping with and resilience is a function of your brain. It's a function of the maturation of your brain.
Fully matured, जैसे जैसे हम mature होते हैं, this TFC prefrontal cortex takes over. So ये जो ब्रेकिंग मैकेनिज्म है, अगर हम कहें कि बच्चों में कम होता है, so they are more impulsive. Adults by training they become wise because they are able to inhibit their action. मुझे गुस्सा आया तो मैं अपने एक्सप्रेशन को रोक पाऊंगा as compared to my son. अगर गुस्सा आया तो वो ज्यादा एक्सप्रेस करेगा. So I think what Sadiqa was saying, I agree to that. This inhibitory mechanisms develop mature over age. तो इसलिए बच्चों में अगर they are overstimulated, they are more likely to commit certain acts and maybe repent later. Thank you.
Thank you very much. Now we'll move to the conclusion and votes of thanks. For this, I would like to invite Ms. Marilena. She's a psychiatric social worker in the Department of Psychiatric Social Work. I request her to conclude the session and give votes of thanks.
Hello, everyone. Thank you for joining us today. On the occasion of World Suicide Prevention Day, it was very important for us to discuss the pressing issues that have been brought to life by the current pandemic. The pandemic has led to profound psychological and social consequences. That is not just people in the country, and also to chart a way forward that will help people cope with the situation. I, on behalf of Department of Psychiatric Social Work, LGBRIMH, would like to take this opportunity to thank the director of our institute, Dr. S.K. Devi, director, and also the members of the organizing committee, Dr. Jyoti Hazarika, who is also the medical superintendent, Dr. Sonia P. Devi, professor and head of Department of Psychiatric Social Work, Dr. Arif Ali, assistant professor, Department of Psychiatric Social Work, Ms. Guli Nath, psychiatric social worker, Ms. Rituparna, psychiatric social worker, for having put together a successful webinar. Thank you for your generosity in organizing the webinar with a group of outstanding academicians. I would like to thank Dr. Sonia P. Devi, professor and head, Department of Psychiatric Social Work, for welcoming everyone with a warm welcome. It's always a pleasure to hear your gentle and generous words. I would like to thank the director, Dr. S.K. Deori, for addressing the audience. We do appreciate the time you took to bring us to this important and enticing message. Thank you, sir. My heartfelt gratitude to all the speakers for having accepted our invitations to be part of this webinar. The purpose was to raise awareness of suicide and suicide prevention, and in this context, the webinar yielded many interesting discussions that will equip the mental health professionals with better knowledge on how to address the global concerns. Dr. Kamal Kalita, Associate Professor, Department of Psychiatric, Thank you, sir, for having been on this panel. Your observations about working together to prevent suicide and examples from the country and the rest of the country has been how to deal with the concerns and also raising awareness. But a new angle to this conversation, we shone light on how rural and urban has different ways of coping with it. We also spoke about how the factors are also different in these two social segments and what are the ways to address it. It does pave the way on how to go about raising awareness in the near future. I would like to thank Professor Dr. Sidicha Sahu, Discipline of Psychiatry, School of Medicine, University of Queensland, Australia, for his presence here with us today. Dr. Sahu, over the years, have done an extensive work on clinical and public health aspects. Today, I would like to take this special opportunity to also thank you for your elaborating and also addressing the factors that were related to mental health issues, such as anxiety, post-traumatic stress disorders, general anxiety disorder relating to the pandemic, and also including the social factors such as the stigma related to the pandemic. It was indeed a very thought-provoking session. Thank you, Dr. Alim Sadiki, psychiatric consultant from Lucknow, UP, with an experience of 19 years in the field. You have made yourself available for this, and also your insight about the biopsychosocial perspective has been provoked some entire knowledge to deal with suicide and also raise awareness. This session has brought to light the pivotal topics that needed to be addressed. Ms. Sabah Rahman, Deputy Associate Editor, at Indian Express. Thank you, ma'am, for your time today. Media does play a very huge role in influencing the mental state of the people. Having said that, let's also try to focus on the positive side of media, which has definitely helped create a lot of awareness for suicide prevention, and the session on how media portrays suicide was very remarkable, for it gave us a very completely new perspectives on how to address mental health issues, especially during COVID-19. More and more people have joined conversation that has championed by the media and that are far more involved than they used to be. Thank you once again to all our speakers. We would also like to thank the members of the advisory committee, Dr. Arun Jyoti, Dr. Shobana, Dr. Priya Saxena, Dr. Vijay Gogoi, Dr. Noor Nehar Ahmad, Dr. Indrajit Mr. Vikas, PhD scholar in past, for your well-timed support with the live streaming of Facebook and YouTube. And also, I would like to thank Dr. Vijay Gogoi for providing us the digital platform to conduct the program, and Mr. Kishore, Mr. Nirmal Basumatri for technical support, Mr. Puran Deka for his consistent support for assisting this webinar. Thank you to our media consultant, Ms. Priyanka Saikia, and our media partner, Tezpur Bus, and Mr. Utpal Gora for the technical support. My sincere appreciation for my fellow webinar coordinators, Mr. Nilesh, Mr. Abhijit, Ms. Srini, Ms. Adipriya, and Mr. Stephen for enabling a smooth session, your excellent management of what has turned out to be a successful and highly stimulated webinar. Today, we have a good number of nearly 800 registrations. 250 participants were on Google Meet, and the rest of the participants were on live streaming platforms such as Facebook and YouTube. Hope in the near future, we will be able to accommodate more and more participants in our forthcoming webinars. I thank all the people who have participated overwhelmingly and made the sessions a successful and productive first day session. Please feel free to fill out our feedback forms, which will be provided to your respective mail IDs, and online certificates will be provided on the same. I do look forward to another engaging session tomorrow. Our speakers for tomorrow are Dr. Anish Charan, Associate Professor from the Department of Psychiatric Social Work Enhanced, Ms. Priya Sridharan, Associate Professor, Department of Psychiatry, St. John's Medical College, Bangalore, and Mr. Bharat R., PhD Scholar, Department of Psychiatric Social Work, Enhanced, Bangalore, and Ms. Lakshmi Vimla, PhD Scholar, Department of Psychiatric Social Work, Enhanced, Bangalore. So thank you very much. Have a pleasant evening.
Thank you, all of you. Ma'am, final comments? Sonia, ma'am?
You want me to finally close the session, is it?
Yeah,
We have a wonderful presentation from our speakers from all across. I think we have covered all categories of people, from the media, from private psychiatry, as well as from, overseas psychiatry, plus internal, home-based, rather from in-house psychiatry, Dr. Kamal. And it has been fairly a good opportunity to discuss various aspects and, the way the world is turning. And I think suicide and its ramifications is a hot topic now, and it's across the board. Everybody is talking about it. But I think we need to go further than this. And I think we had the way that the national strategy about national strategy for suicide prevention. The national strategy has been formed, but it is not trickled down to the ground level and definitely not implemented as such. But I do know of one major NGO that is really spearheading the prevention of suicide. That is and we need to take a little bit of cues and ideas and programs that they are having in order to. In fact, they are the people behind the formation of the National Strategy for Prevention of Suicide, and I think we should look forward to looking at their programs in order to incorporate into some of the activities that we could be doing. And somewhere I think there was also a question in which it said that we need to have most of the. I was just prior to this webinar, I was just looking at the online services available by the various NGOs. The private sector is much more active in this area, more than the government sector and the prevention. The online services. It is most of the time the suicide prevention. Online services are available from 9 to 5. Which is really not the period or the time in which most often the suicide happens, or the help seeking of the psychological first aid is needed, or the crisis intervention that is needed. It's most of the time early morning hours that persons often end up into the activities of suicide. It's very important to have round the clock suicide prevention online services, and that is something that should be made. If an NGO or if a private services are projecting online services, it should